Hello, my name is Kristine Domingo. I will be presenting today's topic on treatment of motor symptoms of Parkinson's disease. I am a movement disorder specialist at the University of Minnesota. Advancing Parkinson's disease motor signs and symptoms that includes increased motor severity, motor fluctuations such as wearing off and dyskinesias, and I'll talk more about this in upcoming slides. Unpredictable responses to medications, nighttime off periods, early morning akinesia or difficulty moving because of the rigidity, freezing of gait, postural reflex impairments, or basically a difficult time keeping their balance or standing straight, increased falls, and then dysphagia or difficulty swallowing. So it's always important to ask a patient with Parkinson's disease about their typical day. And so here's a little diagram here on the right of what a quote unquote typical day would be like of a person with Parkinson's disease as they take their medication. And so early in the morning, they'll take their medication, and throughout the night, if they haven't been taking any medication at all, or their levodopa levels will be a little low, so they'll start to feel those symptoms, or potentially an early morning akinesia at that time. So they'll take their first dose, and then the levodopa levels in their plasma will increase, and they'll start to notice a benefit in their symptoms. And then as time continues, the medication is metabolized in their system, and then they start to notice worsening symptoms, and then this wearing off period here, where they have an off time, and then they continue to take their medication, and the pattern continues. And so it's really important to be able to ask your patient, reasons for why or when they would have these off times. So it's important to keep track of your symptoms throughout the day as well as the night, along with timing of when you take your medications, and then also when you take your meals, because sometimes your meals, especially protein, can affect the efficacy of the absorption of medication. And I'll talk more about that in later slides. So I just wanted to talk about levodopa-related motor fluctuations in Parkinson's disease. And so I've spoken now a few times about wearing off. And so wearing off is basically when a patient with Parkinson's disease will take their medication. So here it's levodopa, and they don't notice the medication start to kick in or take effect until much later on, a lot later than what they expect, or when they expect the medication to start working. And then after a period of time, that's when they start to notice improvement in their symptoms. And then we have a delayed on. And so that is when someone takes their medication and they don't really notice any effect for some period of time. With the wearing off, they'll take their medication. There's a little bit of a delay, and then the medication wears off sooner than what they expect. So that's what wearing off means. So you would expect potentially that the medication lasts this long in a period of time, but rather than lasting that period, it's shortened. And then with delayed on, they take their medication. There's a period of time where they don't notice any improvement at all in their symptoms. And then after a longer period than they would expect, that's when they start to notice benefit from the medication. And then you have dose failures, and so or a failed dose, and that's when a person will take their medication and they don't notice any benefit at all, even after taking that second dose. And after that second dose, or the next dose, they'll start to notice benefit in their symptoms. And so for delayed on as well as dose failures, you really have to think about or consider protein competition. And so, levodopa competes for the same receptors as protein. And so if somebody takes their medication, the Carbidopa Levodopa, and they take a high protein meal along with it, what happens is the medication is not absorbed because it's competing with the protein, and what's absorbed is the protein and not the medication, not the levodopa. And so that can account for some of this delayed on, or even a dose failure. So that's why it's really important to keep in mind, what times you take your medication, and then also your meals and what your symptoms are. And then you have this last type of motor fluctuation called random on and off. And it's exactly what that means, is that someone will take their medication, they'll notice an effect, and then despite taking their medications consistently throughout the day, there's no real predictable measurement of how long the medication will last, when it starts, and then when the wearing off begins. And so that's when it becomes a random on and off. So it could be just, inconsistent, a dose effect, or delayed on, that kind of pattern, which is unpredictable. So with advancing Parkinson's disease motor signs and symptoms, I wanted to talk about dyskinesias. And there are three main types. There's peak dose, there's diphasic, as well as dystonia. So I want to draw your attention here to the diagram on the right. And so in the blue, that is when the patient is on, or has a good response to their medication, to the levodopa, or whatever medication they're taking. Here, they're saying levodopa. And so when the plasma levels of levodopa increase and reach a certain amount, a high dose in the system, what starts to happen is potential for dyskinesias, and that's what's in the yellow shade here. And then when the medication wears off and levels of plasma levodopa is low, that's when you are in the off state, or when you have most symptoms of Parkinson's disease. And so we really want to be in this kind of blue zone here, which sometimes can be very difficult. And so in talking about dyskinesias, you have peak dose dyskinesias, which is the most common type of dyskinesia. And it correlates with the levodopa plasma levels, and it affects the upper limbs, the head, the trunk, potentially, and it can look choreic in description. So that kind of means like a dance-like movement affecting those particular body parts. And so peak dose means they'll take their medication, and as the levodopa increases in their system, at the very peak or the max dose of the levodopa concentration in their plasma, that's when they start to notice the dyskinesias. And then you have diphasic dyskinesias, and that is when dyskinesias occur at onset. So they'll take their medication, and then they'll have their dyskinesia at onset of the medication, and then also at the end of the dose. And that occurs more so in the lower limbs, but it can occur in other areas as well. And then you have dystonia. So dystonia is basically a fixed posturing, or potentially curling of the toes, or it feels like a muscle spasm. Oftentimes it may affect the lower legs, but again, can affect other body parts as well. And so oftentimes dystonias occur as off-period dystonias, or more so in the red zone, when the plasma levels of levodopa is low. And dystonias can be painful. So in terms of management of Parkinson's disease, it helps to be a part of a team. My talk today will mainly be on medication management and therapies, but of course, it's always helpful to get physical therapy, occupational therapy, and speech therapy involved early on, or even throughout the disease course. And we often talk about and recommend the Big and Loud program, which is an excellent program for patients with Parkinson's disease, helping with their movements as well as their speech and communication. And then, as I said before, exercise is something that we always recommend and promote in whatever safe fashion that they can execute it. So recumbent bike, Tai Chi, yoga, boxing, etc. And then, of course, it's really important to have social support around you, either with family or other healthcare providers or social work, nursing staff, whatnot, therapists. And then also there are treatments that are surgical options for management of Parkinson's disease, including deep brain stimulation and Duopa, which I will be talking about in later slides. So here are the medication options for symptomatic treatment of Parkinson's disease. And as you can see, we've got quite a number of agents that we could use in our armamentarium, which is a great benefit when treating someone with Parkinson's disease. And I'll be talking about each medication class. So this is a review done by the International Parkinson and Movement Disorder Society. It's an evidence-based medicine review on treatments for motor symptoms of Parkinson's disease. And so based on the review, they found that there was no effective neuroprotective agent available. Looking at my previous slide regarding all those medications, so none of them have a neuroprotective effect. In terms of monotherapy, these medications are efficacious, including levodopa, dopamine agonists, and amantadine. And I'll talk about this a little bit more with amantadine. That mostly helps to treat tremor, and it has a modest benefit in treatment of that if you use it early on in someone's disease course. For motor fluctuations, these medications are considered efficacious, including dopamine agonists, levodopa gel intestinal infusions, or otherwise known as Duopa, COMT inhibitors, Mao B inhibitors, zonisamide, and deep brain stimulation therapy to the bilateral STN and GPI. For dyskinesias, it's considered efficacious to treat with Duopa, amantadine, and then also DBS to bilateral STN and GPI, as well as clozapine. So let's delve into medications now. So this will be the bulk of my talk today. So Carbidopa Levodopa, the other name for it is Sinemet, is the gold standard treatment for motor symptoms of Parkinson's disease, and it has been for the past 50 years. This is, as mentioned in the other slide, it is efficacious in terms of monotherapy for patients with Parkinson's disease symptoms, and there's no evidence of enhanced disease progression with this medication, either starting it or being on it. It's most effective overall to treat motor symptoms of Parkinson's disease, and that includes rigidity, the tremor, bradykinesia, as well as gait disturbance. I say plus or minus because this has variable effect on patients for improving their gait. And it's really important to be able to discuss with your patients realistic expectations when starting any type of therapy. So Sinemet does not treat things like postural instability, or is not intended to treat things like postural instability, hypophonia, or that soft volume of their voice, sexual dysfunction, excessive sweating, constipation, or dementia. Non-motor side effects include nausea, orthostasis, sleepiness, hallucinations. But in terms of these particular side effects, Carbidopa Levodopa has less of those types of side effects as compared to other PD medications. Motor side effects include dyskinesia, wearing off, and the on and off phenomenon. And with Sinemet, for a patient with Parkinson's disease, by mid to late disease, most often a patient will be on this medication. And so the diagram on the right shows the different doses of Carbidopa Levodopa. 25/100 is the most common dose that a patient would be started on. And Sinemet is composed of two medications, Carbidopa as well as levodopa. And so Carbidopa acts as kind of a bodyguard to levodopa, so that the levodopa is not broken down in the periphery, and acts to be carried through the blood-brain barrier into the central nervous system, where it can act to treat the motor symptoms of Parkinson's disease. Without Carbidopa, levodopa would be broken down in the periphery and cause symptoms like vomiting. And actually, Latin for Sinemet, sin is without, and emet is emesis. So Carbidopa prevents the degradation of levodopa in the periphery, which then prevents vomiting. So without vomiting, sin emet. So this is a medication that is best taken 1 hour before a protein-rich meal or 2 hours afterward, because as I had said before, levodopa is absorbed via amino acid transport system and therefore competes with dietary protein for absorption into the bloodstream. And so if you eat a high protein rich meal and take the medication along with it, your body will absorb the protein and not so much the carbidopa levodopa. And so you will not have its maximum effect, unfortunately. So take the medication 1 hour before a protein rich meal or 2 hours afterward. So here are the different formulations of carbidopa levodopa. You have IR, which is the shortest duration of action. Typically onset is between 30 to 60 minutes. Oral disintegrating tablet or Parcopa is similar in duration to the IR levodopa and does not require water. It actually dissolves on the tongue, but that does not ensure a faster absorption. CR controlled release or extended release is a slightly longer duration of action of levodopa, but it's slower as well as an erratic type of absorption. So most often we use it for bedtime dosing. And so the comparison between 200 milligrams of CR levodopa is about 150 milligrams of IR levodopa because of that slower and erratic absorption. You have Stalevo, which is a combination of carbidopa, levodopa, as well as entacapone. And then extended release Rytary, which is the longest duration of action in terms of the levodopa formulations. And then Duopa, which is the levodopa intestinal gel administration, which is administered through an external pump. And it offers 2 hours or more of on time. Then you have Ambrisia, which is the inhaled rescue form of levodopa intended to treat off episodes. And I'll talk more about these medications. So here we'll talk about Rytary, and here are the different doses of Rytary. You can see it goes from 95 all the way up to 245. Rytary combines immediate release levodopa as well as extended release or controlled release levodopa. And these capsules contain beads of both the IR and ER formulations. And it's a rapid onset of action with the IR with an extended effect from the controlled release beads. And so it doubles the duration of effect of regular levodopa. So it may increase on time by about 1 hour or more. Typically it's dosed between 3 to 4 times in the day, and it should be swallowed whole as a capsule, or you can actually open up the capsule and sprinkle it on patients' food such as applesauce. So this is a medication that is intended to treat motor fluctuations and particularly the wearing off effect of motor fluctuation, and is not indicated for initial treatment. So let's talk about the advantages of disadvantages of Rytary. So advantages, you have fewer doses during the day. So you can imagine if someone's taking it every 3 hours and they can extend it by an extra hour, that can provide benefit for someone's quality of life, or even more than an hour. And so the change in levodopa doses of Rytary are smaller increments. And so that potentially could mean that you have more control of your motor symptoms because you're increasing by smaller amounts, and then potentially could avoid a side effect like dyskinesias. If someone's taking nighttime dosing of Rytary, you potentially could have less symptoms during the night and then improved sleep as a result of improved Parkinson's disease symptoms. So disadvantages of Rytary is that you're potentially having to take more pills in a single dose, even though it's less throughout the day or less intervals throughout the day. And then sometimes switching from IR levodopa to Rytary can be a little bit cumbersome. The conversion in switching from IR to Rytary isn't an exact science and requires trial and error. And so patience from the patient. in order to find that right dose, because sometimes you could calculate it to be a little bit too much and they could be dyskinetic and be uncomfortable, or they could be too low and they could be feeling stiff, and it takes time to adjust. So it really helps to work with a pharmacist to be able to find that right adjustment, because you'll likely talk with the patient for more times during this transition period. Also, brand names may be more expensive. And then this, again, as I said, this is not made for initial treatment of Parkinson's disease, more so to treat motor fluctuations, particularly the wearing off effect. So let's talk about dopamine agonists. So mechanism of dopamine agonists is that it mimics dopamine in the brain. It can be used as a monotherapy early on in the disease, and it's approved for early and advanced Parkinson's disease symptoms. You can add a dopamine agonist to levodopa to reduce off time, and it helps to improve motor scores of Parkinson's disease, delay dyskinesias, and it's less potent than levodopa in terms of treating the motor symptoms. Side effects include nausea, dizziness, orthostatic hypotension, pedal edema or swelling, drowsiness with sudden sleep attacks, and impulse control disorders, meaning a change in behavior where potentially you could be watching more pornography, behaving in more sexual acts, over shopping, gambling, or overeating. So these are always things to ask the patient about, or ask their family members about if there's been a change in behavior at all after starting a dopamine agonist. So things to consider is that dopamine agonists are more prone than levodopa to cause symptoms like hallucinations and confusion. So you really have to, think hard if you want to start this medication in an older patient, and potentially even avoid it for people who are older, and especially for those who are demented. Here are the different medications of dopamine agonists: pramipexole, ropinirole, and rotigatine. And you can see the different doses that one can take in milligrams per day on the different doses available in each of these medications. And you can see that pramipexole and ropinirole come in IR, or immediate release, and extended release formularies. And that rotigatine is a 24-hour patch that is worn on the skin, and that's how they receive their medication. And you can also see the half-life of dopamine agonists are longer than levodopa. So early on with studies, we had seen that the onset of dyskinesia was less with dopamine agonists, and then also the half-life was longer. So when comparing, whether to start a dopamine agonist versus levodopa, because of those factors, people tended to lean more towards dopamine agonists. But I'll talk more about that in a little bit. Oh, also the half-life of rotigatine is about 5 hours, and that's after the patient removes the patch from their skin. So as the patch is on, the medication is being provided to them through their skin, and then when they take it off, they have a half-life of about 5 hours after removing it. So here is a depiction of the rotigatine or Nupro patches. Here's the different doses of the patch, and then also where you can apply the patch on different areas of the skin. So they always recommend to change the location of where you place the patch in order to avoid irritation in the skin in that area. And that's something that you wear for 24 hours. So side effects, I just wanted to compare levodopa with dopamine agonists. So levodopa is more so associated than dopamine agonists to cause nausea, dyskinesia, motor fluctuations, and a condition called dopamine dysregulation syndrome. And so this is akin to being addicted to dopamine. So despite having relatively controlled symptoms and maybe even dyskinesias from having too much dopamine in their system, they're finding that they're wanting to take more dopamine and more dopamine to better improve or even avoid their motor symptoms of Parkinson's disease. So they really truly become addicted to taking medication, which then, of course, if you take too much of carbidopa, levodopa, you could potentially lead to side effects. And then dopamine agonists, more so than levodopa, can lead to impulse control disorder, drowsiness with sudden sleep attacks, hallucinations, orthostatic hypotension, and pedal edema with erythema. So when considering whether to start dopamine agonists versus levodopa for initial therapy, there's a couple of things to keep in mind. Dopamine agonists have less risk for dyskinesias and motor fluctuation within the first 5 years of disease course in Parkinson's disease, but it's also associated with more side effects, as I had mentioned in the previous slide. With levodopa, you have better efficacy for treating the motor symptoms of Parkinson's disease. You also have fewer side effects, and there is no evidence of neurotoxicity. However, keeping all of this in mind, we have to always, with treating Parkinson's disease, there is no right or wrong answer. There is no one size fits all in terms of what's the best medication to treat everyone with Parkinson's disease. It's a therapy that's individualized and something that you discuss together to communicate. It's a type of, you have to communicate with the patient as well as the physician, and consider what's the predominant symptom that you're wanting to treat, disease severity, side effect profile of the medication you're considering, as well as cost to the patient. So there are several medications that prolong the effect of levodopa, including COMT inhibitors and MAO B inhibitors. And so these two classes of medication provide about 1 to 2 hours of increased on time with effective treatment when combined with levodopa. So this must be given or taken with levodopa because on its own, COMT inhibitors and MAO B inhibitors do not have independent action on their own. So these are the examples of COMT inhibitors. And COMT stands for catechol-O-methyltransferase. And COMT metabolizes levodopa primarily in the GI tract, and that the peripheral COMT blockade improves CNS levodopa levels, which helps treat motor symptoms. It helps to extend the clinical benefit of levodopa by reducing off time and increasing on time. These are the different types of COMT inhibitors. Anticapone peripherally blocks the enzyme COMT, and these are the side effects as associated with. A unique side effect of entacapone is the orange discoloration of urine, tears, and sweat. So just keep that in mind and tell your patients about it before they discover it on their own. These are the typical doses of this medication. Again, entacapone or COMT inhibitors must be taken with levodopa in order for it to provide its therapeutic benefit. And again, there's Stalevo, which is an option of levodopa, carbidopa, and entacapone all in one medication. Opicapone is the new kid on the block in terms of COMT inhibitors and was FDA approved in 2020. And so again, it's got that peripheral blockade of COMT. These are its side effects, including constipation and dyskinesia. And it's a once daily dosing, which is a really nice option for this medication. And so then you have tolcapone, which has central and peripheral blockade of COMT enzyme. And it's rarely used nowadays because of the risk of hepatic failure. Now we have MAO-B inhibitors. And so MAO-B is an enzyme in the brain that breaks down dopamine. It effectively, or it works to improve motor features of Parkinson's disease and can be used as a monotherapy or as an adjunct to other medications for Parkinson's disease, including levodopa. So this medication helps to decrease off time. So these are the side effects associated with this medication. And the caveat is that MAO-B inhibitors have many drug interactions, such as to antidepressants, a couple of medications for anxiety, and dextromethorphan are examples. In combination of low doses of SSRIs, that's been shown to be safe when using MAO-B inhibitors. But you really have to monitor them for potential for serotonin syndrome. These are the different medications of MAO-B inhibitors. You have selegiline, which is taken twice a day. Keep in mind that you want to make sure that second dose is taken early on in the afternoon to prevent sleep issues or insomnia. This is a medication that's metabolized into amphetamine. So you want to warn patients who potentially are tested for amphetamine because they could test positive. And then this helps to reduce off time by about 1 to 1.5 hours. Then you have rasagiline, which is taken once daily. And this is not metabolized into an amphetamine, and it reduces off time by about 1.2 hours. You have sulfonamide, which is also taken once daily. And based on the studies for this medication, after 24 weeks, it helped to increase on time by about 0.8 hours. And these are the effects, including modest increase in dyskinesia, excuse me. Amantadine is an NMDA antagonist that increases dopamine release and blocks dopamine reuptake, therefore increasing the concentration or the amount of dopamine in the system. It helps to treat patients early on for a tremor, which again, as I've said, has a modest benefit when treating this particular symptom. Most often, this medication is chosen to be used in mid to late disease, for Parkinson's disease, for bothersome levodopa-induced dyskinesia. And this is the dose for which we may start or use amantadine. And here are the side effects. So we really have to pay attention to the anticholinergic side effect, which means dry eyes, dry mouth, urinary retention, constipation. It can be associated with leg swelling, hallucinations, likely from the anticholinergic effect, insomnia, lightheadedness, nausea, as well as levator reticularis, which is provided. There's an example here of levator reticularis, which is kind of a blotching of the skin. Now, this is not painful, but as you can tell, it can be unsightly. And if you choose to stop the medication, this resolves. So we have to take caution when we consider this medication for patients who have renal insufficiency or failure, because amantadine is secreted unchanged to the kidney. So you really have to consider a dose adjustment for these particular patients. There are different formularies of amantadine. You have Gocovri, which is an extended release amantadine. And so this is approved for treatment of levodopa-induced dyskinesias. And it also has been shown to reduce off time by about 0.9 hours. And here are the side effects associated with Gocovri, and this is the doses of Gocovri. Osmolex is approved for Parkinson's disease, and then also here are the doses for this medication. Anticholinergics are another type of treatment for Parkinson's disease, and the idea is that you restore the acetylcholine dopamine balance by treating with anticholinergics. So it's most useful in young patients, because as you can tell with the anticholinergic effect, we would want to avoid those side effects in the elderly, and it's useful for young patients with tremor predominant Parkinson's disease symptoms. It's effective for tremor, as I mentioned, and here are the side effects when using this medication class. And again, you want to avoid it because of these side effects for patients who are older. Istradefylline is an adenosine A2 receptor agonist. And so adenosine A2A receptor stimulation may lead to abnormality in signals for motor control in Parkinson's disease. And so istradefylline is used as an adjunctive therapy to Carbidopa Levodopa to decrease off time in Parkinson's disease. So here's the dose. The doses of istradefylline, and it's taken once daily. And it approximately decreases off time by about 1 hour and improves motor symptoms. Side effects include mild to moderate dyskinesia as well as constipation. So now let's talk about on-demand therapies. So the on-demand therapies are mostly considered for patients who have unpredictable off time. So oftentimes this is something that's considered when patients with Parkinson's disease are later on in the disease process. And off times can be related to several different things, including stress, after meals or postprandial, end of dose or shortened benefit from levodopa, and delayed onset. It could also be associated with partial response or failed response to their Parkinson's disease medication. So in order for it to be a successful on-demand therapy, it should have a quick onset of action, should be well tolerated by the patient, and have an easy administration. So here is apomorphine or Apokyn, which is a subcutaneous administration of this medication. It's a type of dopamine agonist. And it's the first kind of rescue medication that was out in the market. And it's treated, or it helps to treat sudden off periods. So its response is equal to levodopa. And after it's injected, so as you can see here, it's a very fine, about 29 gauge needle, but it's something that you have to inject into your body part to get the medication. But once injected, its onset is a little bit less than 10 minutes, and it lasts between an hour to 2 hours. So it's got a short duration of action, so it should not interfere with the regular dosing of a patient's Parkinson's disease medication. The other medication is, so the newer one, this was approved in I believe 2020, but this is apomorphine, but a sublingual distribution of apomorphine, again, a dopamine agonist. It's got this bilayer film where it has the medication and also so here, the bilayer film, here's the medication, and then a pH modifier that helps improve the permeation of this medication. So this is a medication that is administered under the tongue, and after that, that's how it's incorporated into the circulation. And because of that, it avoids GI delays as well as that first pass effect. And as you can see here, it's available in different doses of strength. So let's talk about adverse effects and special considerations for sublingual apomorphine or KINMOBI. So it's associated with these side effects: or pharyngeal irritation, which in about 70% in the study led to discontinuation, nausea, somnolence, orthostatic hypotension, as well as prolonged QT in one patient. Things to really consider with this medication is that 3 days prior to starting KINMOBI, you are pre-treated with an anti-nausea medication called trimethylbenzamide, which helps decrease the side effect of the nausea. You want to be able to drink water before administering this medication in order for it to be better absorbed. And as I said, it's applied under the tongue. It must be kept under the tongue in order for it to be dissolved and it has to be completely dissolved in order for it to get into circulation. So oftentimes that takes about 3 minutes. Maximal dose is about 5 doses per day. And this medication is contraindicated with use of 5-HT3 antagonists like ondansetron or Zofran. Next, we have the inhalational levodopa or Ambrisia. This is approved for intermittent off periods in Parkinson's disease. You can take up to 5 doses per day, and it decreases off time by about 0.8 hours in the day. This medication is provided with these capsules, which contains the medication and should not be swallowed. And so you take this capsule and you administer it into this Ambrisia inhaler. You press down, once this is inserted into the inhaler, you press down on this white part of the inhaler, which punctures the capsule and then allows for you to be able the patient to put their mouth over this mouthpiece and then simply inhale the medication. So again, we should not swallow the capsules. It's administered via this Ambrisia inhaler. And it was not shown to change in pulmonary function tests. So let's talk about surgical therapies for Parkinson's disease, and that includes Duopa as well as deep brain stimulation. For Duopa, this provides a continuous release of levodopa during the day via this external pump. The medication is provided via this drug cassette, and then you can set the pump to be able to administer the medication at a particular rate that you set. And so the pump is connected to this tube, tube, and the tube is connected to the jejunum. So as you can see, this is a surgical procedure to insert the tube. The levodopa is directly delivered to the small intestine, where the levodopa is best absorbed, which allows for a more steady state of levodopa throughout the day. And because of that factor, there are no issues with delayed gastric emptying or slow GI transit. So with Duopa, it's approximately about $60,000 per year. The company does offer coverage and reimbursement support, which is a good opportunity for all patients to take advantage of if they choose this type of therapy. And as you can see, there are a large percentage of complications associated with this therapy. So 35% with device insertion, then they have abdominal pain, nausea, postoperative wound infection, and then also 40% of patients have levodopa associated peripheral neuropathy after starting this medication. When evaluating these patients for the peripheral neuropathy, they were found to have increased homocysteine, reduced vitamin B12, increased MMA, and reduced vitamin B6. So this is something to keep in mind for anybody that you potentially consider to start this therapy, and especially for those who start the therapy, is, it might be a good idea to start a daily vitamin supplementation to hopefully, get ahead of this if possible. And then we have deep brain stimulation. And so this is a reversible procedure that involves placement of a medical device called a neurostimulator. And this neurostimulator provides electrical impulses through the wire to electrodes, or this lead, which contains electrodes, to specific targeted areas of the brain, which help to control symptoms of Parkinson's disease. So sometimes this is referred to as a brain pacemaker. And this is a type of treatment considered for Parkinson's disease patients who have motor fluctuations, wearing off, dyskinesia, or medically refractory tremor. Now, this is not a cure for Parkinson's disease, and it helps primarily to treat the motor symptoms of Parkinson's disease, and that includes tremor, bradykinesia, and rigidity. So it's really important to be able to have this conversation about realistic expectations for patients, because you want to be able to provide the best type of therapy and be on the same page of what goals that the patient wants to treat in terms of their symptoms and what's attainable. So this is a type of therapy that's been approved to treat Parkinson's disease since 1997. So here is a video of a patient with DBS, and it's a demonstration of their symptoms being treated with deep brain stimulation. So here, DBS therapy is off, and here, DBS is on. Now she's turning the therapy back on. Again, therapy off and versus therapy on. And you can see that the DBS really helps to treat his tremor and the slowness. And it's actually quite profound. And so I just wanted to talk about University of Minnesota. We have an amazing DBS program that utilizes neurologists who are movement disorder specialists, neurosurgeons, neuropsychologists, psychiatrists, a wonderful nursing staff and researchers to help patients who are interested in DBS, who are under placement at DBS and also DBS therapy. And then we're actively involved in research regarding this as well. So here are some upcoming therapies to keep in mind, or just kind of potentially keep your eye out for. This is Neuroderm, or ND0612. This is a continuous subcutaneous infusion of Carbidopa Levodopa, and it allows for stable plasma levodopa levels similar to Rytary, similar to Duopa. And it helps to reduce off times without troublesome dyskinesias, as seen in studies done on it currently. And its limitation is that it's only able to provide up to 900 milligrams per day of levodopa. Another upcoming therapy is the Accordion Pill, or AP09904. This is a gastric retention capsule. So this is a medication that's swallowed, and then once it's swallowed, it opens up as an accordion, as the name suggests, and it has multiple layers combining IR and ER formulations of levodopa. Its plasma half-life is about 5 to 7 hours, and it's given about 3 times a day. And it's currently in phase 3 studies comparing this medication, the Accordion Pill, to IR levodopa. Here are some resources for Parkinson's disease patients, if you're interested. This is a part of the support group that surrounds patients with Parkinson's disease that have been very beneficial. And now I'll talk, or I'll take questions and start our discussion. I first want to say, before we end this, thank you so much to APDA for allowing me to talk, or present this lecture. And also thank you to the University of Minnesota, my mentors, colleagues and friends. It's been, I just wanted to say thank you. All right, I'll start the questions now. Thank you very much.
Thank you so much, Kristine. I thought it was really, really helpful to have that extremely comprehensive review of the many, many treatment options for the motor symptoms of Parkinson's. So thanks so much for taking the time to share your expertise with us. And
absolutely.
Wonderful. And we have several questions from our audience. One of our audience members said he was just diagnosed with Parkinson's, and his doctor suggested that he take the medication at nighttime versus morning. Is there any difference in effectiveness and timeframes?
Sure, that's a great question. So, of course, like I had said in my PowerPoint, there's no one size fits all in terms of treating Parkinson's disease. So you really have to have this discussion with your physician as well as the patient. There have been some studies that show early on in Parkinson's disease that if you treat via nighttime dose, that medication allows for buildup. And then treatment that lasts, that's a prolonged treatment as opposed to just the half-life of about 3 to 4 hours. And so those studies have shown that if early on in the disease process, if you take the medication at night, it can help to improve symptoms because of that longer effect that they've seen in these particular studies. And of course, the caveat to that is if the disease process starts to progress, and this might not be the best option, but of course, that's why you work closely with your physician and you have an active conversation with them regarding what your symptoms are and what you want to be able to treat and what medication to take and how you want to take it.
Great, thank you. That was really informative. And another common question that I see coming through is there any benefit to taking a break from Carbidopa Levodopa dosing for a period of time?
That's also a great question. So I'm going to reach back here, a little history lesson. Back before early on in Parkinson's disease in terms of the history. I shouldn't say far back. It's not too far back, but I want to say in the 70s and 80s, they used to use that strategy and take levodopa breaks. And they found that for some patients, they started to notice a different type of disease or different type of symptoms it's called neuroleptic malignant syndrome. And so if you're a person with Parkinson's disease that's taking a good dose of levodopa and then you completely take a break and stop the medication, you might develop this particular syndrome. And so it's really something to look out for. And because of that, we don't recommend stopping the medication abruptly. You know, this is a really good point to make, that it's and I always have with my patients, when someone takes levodopa and then they start to notice that they require more and more or increased dose of the medication, I always like to explain that it's not because you're developing a resistance to the medication. It's more so because your disease is likely progressing and you're needing more of the levodopa in your system to be able to treat your symptoms successfully. And so, it's not so much that over time you use up the levodopa or the carbidopa levodopa in your system. It's more so likely that your disease is progressing and you need more of it in your system to be able to treat your symptoms.
Great. That's really interesting. I didn't know about that history regarding the carbidopa levodopa breaks that used to be recommended. So that was really eye-opening. So another question here, someone says, let's see. I think someone said, if I would like to switch to Rytary, is there a generic of that?
Unfortunately, not right now. Rytary is a newer type of medication, and it's one of a kind right now where it does combine the IR and CR formularies of levodopa, and so right now it's only there's no generic form of it.
Okay, and I'm curious, I just want to add on to that with my own question.
Mm-hmm.
Do you know, is there usually a time frame when generics become available? Is it like 2 years or 3 years?
That's a good question. I think and this is not my field. So I think in terms of when someone comes out with a new medication, they have a patent on it for about 10 years.
Okay, great. Thank you for answering that. And someone else asked, in your talk, when you were referring to off and on time, are you referring to physical symptoms only, like the physical motor symptoms?
Oh, that's also a great question. So Parkinson's disease really manifests as physical symptoms as well as non-physical symptoms. And so my talk just basically focused on the motor symptoms or the physical symptoms of Parkinson's disease. But when people notice themselves starting to feel off, or when they have off periods, they really start to feel not only the motor symptoms, but potentially non-motor symptoms as well, such as agitation, anxiety, a restlessness for some people. So that's not to say that everyone experiences these off symptoms, but it can manifest as more than just motor symptoms or physical symptoms.
Yeah, and I've just anecdotally heard that as well as at different Parkinson's support groups. So that's something to be aware of. And someone else has asked, how do you know when it's okay to have protein when taking carbidopa levodopa to avoid what you mentioned about, having a lot of protein in your meal that affects the absorption of the drug?
So I always recommend take the medication an hour before a protein-rich meal or 2 hours afterward. Sometimes people can manage with taking the medication 1 hour before and 1 hour afterwards. So it's something that you can just kind of observe in yourself and see what is best. But as a general rule, I say take the medication 1 hour before, 2 hours afterward, to have, to be able to experience the maximum benefit of that, of levodopa or carbidopa levodopa.
Great. I think that's, I'd almost recommend people just write it down and tape it on their fridge, because that's such a helpful piece of advice.
Yeah, absolutely. It's something that we always have to remind people who may be living in nursing homes who get the medication administered to them, because it matters. It matters how they react to the medication, how they respond.
Great. And someone else has asked, what is the best treatment for dyskinesia? And,
Oh.
because you mentioned that dosing of levodopa could be a cause.
So that's a multiple answer question, similar to what I was saying about how there's no one size fits all. So dyskinesias, as I had mentioned in my lecture, is that it could be peak dose dyskinesia. So it means you're experiencing symptoms when the levodopa is the highest concentration in your plasma level. And so a way to treat dyskinesias could be to look at the dose that you're on right now and see if you can tolerate decreasing the dose. And so that's not something that everyone can tolerate. So if they can't tolerate that particular step, then what we do then is add on a medication such as amantadine, which helps specifically to treat dyskinesias, or even Gocovri if they can't tolerate amantadine, because it's a longer acting amantadine formulation. There's several other things that we can consider in terms of treating dyskinesias, but like I said, it's an active conversation you have with your physician, and there's not just a one consideration or one step that you can do to help treat it. There's a couple different things you could do, but those are the two things I would start off with: is see if you can decrease the dose, if they can tolerate that, and then potentially add on a different medication to help treat that particular symptom.
Super helpful advice. And this is why we recommend that every person with Parkinson's see a movement disorder specialist like Dr. Domingo, because movement disorder specialists are the people that are just most equipped to answer these complicated questions that come up with medication management related to Parkinson's. And we have another question here. The person wants to know, what can you tell us about drugs that might slow the progression of Parkinson's? And they mentioned a couple of examples, like exenatide or terazosin.
Could you say that first one again?
Exenatide.
Exenatide.
EXENATIDE. So that's something that they mentioned.
Exenatide. That one doesn't sound familiar to me. But in terms of drugs that slow progression, there is several different studies that specifically try to answer that question. Can we use medications to slow the progression of Parkinson's disease? And so early on in the disease process, some of these studies show that if you start a dopamine agonist or levodopa earlier on, as opposed to waiting until the symptoms really interfere with daily activities, that could be a hindrance as opposed to a benefit, for people that believe that starting a medication later on is better than starting it sooner to save the effects of that medication. And so most of the studies have shown that, starting a medication as soon as Parkinson's disease symptoms start to interfere with their daily life is likely the way to go when you initiate therapy for Parkinson's disease, and that holding off likely will not provide any more benefit. Now, are there medications that will slow or prevent the progression? As of right now, there aren't any medications that do that. As I always like to tell patients, Parkinson's disease is a neurodegenerative process, meaning that we expect it to continue to progress. We expect symptoms to worsen. That's why you work closely with your physician to be able to monitor symptoms and be able to treat as that progression continues. And so again, it's an active conversation. But to answer that question, sorry, it's long-winded, but there are no medications right now that will stop the progression of Parkinson's disease.
Okay, great. Thank you so much. So unfortunately, that is all the questions we have time for today. But, people were really interested in your talk. We had so many questions coming in. And I just want to encourage everybody, if you're interested in seeing a movement disorders expert like Dr. Domingo, contact your local APDA, Information and Referral Center, and we can help get you connected with a movement disorders specialist so that you can get this level of expertise every time you see your physician to help manage your care. So with that, thank you again, Dr. Domingo, for taking the time to join us. We're so deeply appreciative of your sharing your presentation with us today.
Absolutely. Thank you, Anushka, and thank you to APDA. And I just want to mention one more thing. It's important Nope. Okay, so that's it. Thank you very much, everybody. Thank you for your time.
Great. Have a great rest of your day.
You too. Thank you.